Where in Western Easter?
Okay, everybody can take their seats, please. We're going to start. Hi, and welcome. My name is Ruth Tripp, and I'm a Principal Health Promotion Specialist in our health department here at Hennepin County. This last year, I had the opportunity to work with our health equity leadership team in helping them draft a health equity plan for the department. I work primarily on community projects that create environments that support healthy eating, being physically active, and tobacco-free. One of my main projects is working with organizations that serve people with serious mental illness and substance use disorders, folks that are often in touch with the criminal justice system. So I'm eager to hear Dr. Winkelman's talk today. First, before I get started, I wanted to just mention next week there is a Violence Prevention Summit that's part of the Health Equity Brown Bag session. That is on April 2nd, so Tuesday, from 9 to noon at the Brookdale Library. And if folks are interested in registering for that, they should email Molly Schumann, and that's Molly, MOLLY, SCHUMAN at hennepin.us. And a flyer is going around with all of our Public Health Week activities, but you'll see that item listed there, Safe Communities, Public Health Approach to Violence Prevention. So if you can pass that around, that'd be great.
And Molly's in the room for those of you who may want to register in the chat.
Yep, right. Good. So today we're delighted to have Dr. Winkelman with us to talk about health equity in the criminal justice system. Dr. Winkelman's a clinician investigator at Hennepin Healthcare, as well as an assistant professor in the Department of Internal Medicine and Pediatrics at the U. He completed his medical school and training at the University of Minnesota and obtained a master's degree in health and healthcare research at the University of Michigan through our Robert Wood Johnson Foundation Clinical Scholars Program. Dr. Winkelman has expertise in health policy and public health and conducts research in collaboration with partners locally and across the country. His research focuses on the intersection of criminal justice and the healthcare system, with special interest in disorders that disproportionately impact justice-involved individuals like mental health and substance use disorders. Dr. Winkelman's work has been published in many scientific journals, including the Journal of American Medical Association and the American Journal of Public Health. So please join me in welcoming Dr. Winkelman.
All right. Thank you all for being here today. I think I have never given a talk where you can actually give evaluations. So I would love feedback on what was super boring and what was useful, so that if I'm asked back again, I can make it more valuable for you. All right, so let's just jump right in. And if you have questions or comments as we go, I am totally okay if you want to just raise your hand or blurt out a question, and we'll just pause. Otherwise, I'm hoping that we have time at the end for questions. So the first few slides are just going to be some background information and trends with regards to criminal justice involvement and health conditions for people involved in the criminal justice system. And then how I've structured this, again, an evaluation, tell me if this works or not, is there's sort of been the three themes or concepts that sort of emerged for me through the recent work that I've done with Hennepin County. And so I want to, I think they'll be helpful for you all. And to illustrate each of these ideas, I'm going to use a project that I've been involved with that sits at the intersection of healthcare and the criminal justice system. So I'm first going to spend a little bit of time talking about piloting and testing interventions, and I'll talk about some of the smoking cessation work we're doing at the Hennepin County Jail. Then I'll talk about monitoring and informing public health crises and I'll talk about some of our opioid work that I've done with Hennepin County's opioid coordinator, with Peter, and others in public health and DOCCR. And then finally, I'm going to talk about how do we start to understand the intersection of some of these very complex health systems, and I'm going to talk about our Grand Challenges work that's being funded through the University of Minnesota on community supervision in health, and that's a collaboration between Hennepin Healthcare, Hennepin County, and the University of Minnesota. And then I'll have some conclusions, which may or may not be at the end of this. Before I start, I want to make it very clear that none of these projects were the Tyler Winkelman show. They were all conducted in teams, and so I happen to be the one that's presenting this work, but there were many people who have contributed to these projects, and there's no possible way that they could be done without these team efforts. And it would probably take me the full 40 minutes to tell you who all of these folks are. But they've all substantively contributed to these projects. So first, just so that we're all on the same page, I want to go over sort of national trends in the criminal justice system. And I'm sure that many of you have seen slides like this before. So this is the rise of mass incarceration in the United States from the 80s to more recently. And you can see just this enormous rise that starts in the early 80s or even really late 70s. And probably this is not new information for many of you. But to keep in mind, in the United States, there are many more people who are supervised than who are just in a correctional facility. So let me remind you, prison is this green line, which by itself looks impressive, but when you compare it to the number of people who are on community supervision across the country, it's actually a minority of people who are under supervision. And so when we talk about criminal justice involvement, we're talking about both people who pass through jails and prisons, but we're also talking about people who are on community supervision through probation and parole, or maybe touch the court system in some way as well, who don't end up in either of those camps. And I think this slide is from my favorite paper. That's a review article on criminal justice and health by one of our collaborators, Emily Wong, who's at Yale. And it really shows that the scale and rise of incarceration in the United States is unparalleled across the rest of the world. So they compare incarceration rates in the USA in the far right, lower right corner there to what's happening in terms of incarceration across the world, and we're on just like a whole other scale. And so people say, like, well, why is this happening? It's complex. A few of the common reasons that get thrown about are Nixon's war on drugs, so the criminalization of substance use disorders, mandatory minimum sentences where you commit a crime and you're sentenced to X amount of time in prison, sort of no matter what. Three strikes laws where if you commit three crimes, sort of no matter what they are, what the circumstances, you are then incarcerated in prison. And then others will point to deinstitutionalization of mental illness, where the goal was to deinstitutionalize folks with severe mental illness and provide treatment in the community. But instead, many of those people, rather than get treatment in the community, get treatment in a correctional facility. So over this time, you might think, well, maybe crime's just been like going off the charts, and so we've had to incarcerate more people. And that's certainly not the case. Over this time period, crime has actually fallen. And so in the current day, we have some of the lowest crime rates and violent crime rates that we've ever had in the United States. And as many of you know, not all communities have been impacted equally. So this is lifetime likelihood of imprisonment. So 1 in 9 men across all races and ethnicities, 1 in 3 black men, and 1 in 6 Latino men. And so black and Latino men and women are disproportionately involved in the criminal justice system. If you look at sort of other subpopulations like African American men who have not completed high school, it's the majority of those individuals who will spend time in the criminal justice system. And the racial disparities are striking, and we'll get to kind of what that looks like in Hennepin County a little bit later on. And this sort of mass supervision has led to generational effects that also disproportionately impact communities of color. And so this sort of just generally shows the rise of children who are who have parents who are currently incarcerated, and the disproportionate impact that has on African American families. All right, so that's a little bit about what's going on supervision-wise across the country, and then I'm just going to briefly touch on some health condition stuff, and I will get to rates of substance use and mental illness later on in the talk. This is more about chronic conditions and disability, but I think, as many of you probably know, the majority of people in the criminal justice system have either mental illness, substance use disorder, or both. And so this is just some work that we've done from a national survey of individuals who have been arrested. And what we found is that if you've ever been arrested or on probation, this is of people who are on community supervision, so probation or parole nationally. So if you've been on probation and parole in the last year, you're 31% more likely to report being in fair or poor health. And you might say, like, oh, like maybe they just think that they have worse health, but they really don't. But that metric of fair or poor health has actually been well validated and is a very strong and consistent predictor of mortality. They have rates, their rates of COPD, which is a lung disease that's caused by smoking. Those rates are 61% higher. They have 167% higher prevalence of hepatitis B or C. And they have a 47% higher prevalence of disability. And if you look specifically at cognitive disabilities are 70% more common among folks who are on supervision. So the first thing I want to talk about is piloting and testing interventions. And this sort of idea came about from some of our work looking at smoking rates among individuals who were involved in the criminal justice system. And a couple things that you can see. So first, like that top line is folks who have been involved in the criminal justice system in the past year. And the rates like don't change significantly from year to year. They've sort of just stayed the same for the last 9 years. The rate in the general population has gone down, and it's gone down to a significant degree. So that what's happened actually is that smoking rates among individuals in the criminal justice system have remained twice as high as the general population, and the disparity is actually getting worse because rates are improving among the general population. So what we do know about these smoking rates is that it contributes to elevated, increased mortality after release from prison or jail. And so one of the common causes, not the most common, but one of the common causes of mortality after release is cardiovascular mortality. And it's largely driven by smoking, and also contributes to those higher levels of COPD that I mentioned in the previous slide. So we thought this was an important target for a couple of reasons. One, there's clear public health implications. But the other thing is that when you start to think about interventions across sectors, it's also good to like pick topics that like people generally agree upon. And so it's like not that hard to get buy-in that reducing smoking is like a good thing. So we partnered with the Hennepin County Sheriff's Office on a smoking cessation study. And so we are currently recruiting and enrolling individuals in the Hennepin County Jail to a smoking cessation intervention that includes counseling and then nicotine replacement on release. So we're about 20% through that, and the goal of mentioning this is not to sort of talk about our data, but I think even though we're only 20% of the way through recruitment, I think there are a variety of issues that we've learned that are really important to think about. The first is that I have really valued this trial. It's relatively small. It's considered a pilot because it really is going to allow us to make changes before we try to achieve scale. We have learned a lot about trying to implement a public health program in a jail, especially trying to link people on release. And it would have been silly for us to create this massive program and then just see how it goes. It would not have gone well. We are starting small, and we are learning a lot along the way. And oftentimes, it's actually more positive than I would have guessed. And so there is enthusiasm and excitement in places that we didn't anticipate, and I think more leverage than we thought there would be. So that's one thing that I think is really applicable to folks working in county government. Then the other thing that I really want to mention is that experimental designs are critical and feasible. So what do I mean by that? So generally, as you all know, how a program works is that someone decides a program is a good idea, and then they do it, and then 10 years later kind of wonder if it worked or not. It's really hard to know if programs work if you don't think about the design as you are rolling out the program. And so what we're doing is, in this case, we're randomizing individuals. And so they either get standard of care or sort of this counseling and nicotine replacement. You don't have to do that when you roll out a program. There are many other ways to design program rollout that will help you understand if the program works or not, that aren't randomization. And the other thing is that these types of designs are possible even in really complicated systems. We've found that, probably not unexpectedly, following people through system transitions is difficult, but it's possible. And out of the first patients that we have enrolled, every single person has completed at least one assessment post-release from jail. And so there's even folks who have shown up for their assessments because they're so excited to participate, which also was not expected. Any questions about that? So the second topic I want to discuss is monitoring and informing public health crises. And this is work with Julie Bauk back there, who's the Hennepin County Opioid Coordinator, with Peter, and with a variety of other folks in the county. So why did we pick this topic? You've all likely heard about the rise of the opioid epidemic. What you may not know is that most people with an opioid use disorder, over half and 3/4 of folks who use heroin, will pass through the criminal justice system. And the majority of people who misuse or abuse opioids will pass through the court system. So the criminal justice system is a very common contact point for folks with an opioid use disorder. When you leave prison or jail, your risk of death in the few weeks afterwards are 10 times higher than in the general population. That's for any cause of death. If you look at overdose deaths, so your risk of an overdose after release compared to your risk of overdose in the general community is 120 times higher. So it's a very vulnerable period. And this is particularly true for opioids given their side effect profile. So that work was all done nationally or in other states, and so we wanted to know what is the overlap between opioid-related deaths and incarceration in Hennepin County. So we, meaning Peter and others in public health, linked mortality data with jail and prison data across Minnesota in 2015 and 2016. We're looking at two things: the impact on Hennepin County residents and the impact of Hennepin County facilities on all Minnesota residents. The mortality data comes from the Minnesota Department of Health. It's nice and clean and accurate. And then the prison and jail data comes from the Minnesota Department of Corrections, who sort of has a catalog of incarceration data. So what did we find? We found that 1/3 of opioid deaths in Minnesota happen in Hennepin County, slightly above the proportion of residents in Hennepin County. So sort of, if you're thinking about trying to make a statewide impact, creating interventions in Hennepin County is a very good place to start and has the potential to make a big difference on statewide numbers. What we found is that 30% of deaths among Hennepin County residents or across Minnesota happened in the year after someone was released from prison or jail. So about 1/3 of individuals who were dying of an opioid overdose were dying fairly recently after a period of incarceration. And most of the time when folks were dying after release, it was within 3 months of release. So a lot of these deaths are happening fairly shortly afterwards. In terms of the impact of Hennepin County facilities on Minnesota generally, we found that 1 in 10% of opioid overdose deaths in Minnesota, so not just deaths after incarceration, but all opioid overdose deaths across the state, 1 in 10 happen after release from the Hennepin County Jail, the ADC, right across the street. African Americans and Native Americans were disproportionately represented in opioid overdose deaths. And among the folks who were dying after release from jail, the vast majority were staying longer than 24 hours, suggesting that there is some time to intervene. So we provided some recommendations, and I'm happy to say that that these recommendations are currently enacted or being rolled out in some way. So Dr. Rachel Silva is the medical director at the jail, and I'm one of the staff physicians there. And then we work very closely with the medical director at the workhouse or the adult correctional facility on an opioid program they're rolling out. And so we suggested universal screening for opioid use disorders during incarceration, to continue or start treatment for opioid use disorders during incarceration, and to link to community treatment upon discharge. And so that these recommendations have been linked with other efforts that Julie and others in Hennepin County are leading to make a dent in the opioid epidemic. Yeah.
I was just going to ask, did you look at level of offense with how people have been impacted? Meaning,
Yeah.
incarceration for a more serious felony? Was it for a minor misdemeanor?
That's a great question. Peter, did you guys happen to look at that?
We were not able to look at that. I mean, first of all, it was in the jail, it's just a charged offense, so the data is actually not very complete.
Okay,
The data we have.
got it. Yeah, it's interesting. Okay.
Can I ask a quick question?
Yeah.
How are you doing universal screening?
That's a good question. So that is one piece that is in process and not final. But so I can speak to the jail. I don't know exactly what the ACF is doing. But at the jail, every person that comes into the jail gets a nurse intake, like when they arrive. So currently, as part of that intake, it's like a med rec where people share whatever medications they're on so that they can be restarted, and then they're asked about substance use, but somewhat generally. So as part of that intake, we've modified the screener for opioid use. Some of the very standardized screeners to ask about opioid use disorder are sort of long. So we've modified it to be able to be done in a minute or two. It's not perfect, but I think it will at least identify far more people than we're identifying now. I would say, though, as we've rolled out this program, just sort of naturally, nurses have been asking a lot more questions about opioids. So they contact me and our nurse care coordinator to let me know if someone is on buprenorphine and would like to continue it in the jail, if they have a substance use disorder, an opioid use disorder, and would consider starting treatment. So like when I was in clinic on Wednesday, yesterday, of like the 20 charts or people that I reviewed, probably a quarter of them had something to do with opioid use. So it's not systematic at this point. It should be actually in the next couple of weeks. But even without that, sort of identification has increased just because of like knowledge. Yeah. Yeah.
Did you see any increase in smoking since you did smoking cessation with their ability to try to stop the other addiction? Did you see an increase in a different habit?
Yeah, great question. We haven't looked at that. I'm trying to think if there's any research in the back of my mind that's looking at this issue. If I recall, in the smoking literature, when people try to quit smoking, their other substance use tends to get better. I have a few theories about that, but one of the things, if you quit smoking, one, you're probably getting some form of counseling or you're connected to healthcare in some way. But also, a lot has to be going right in your life to quit smoking. So, like, you generally don't quit smoking at, like, the most stressful period of time. And so, actually, one of the secondary outcomes that we're looking at for our smoking cessation study is, do people use other substances less often? Because they're now getting counseling in the jail. It's ostensibly about smoking cessation, but you talk about a lot of stuff during a smoking cessation counseling session, and then they get phone calls starting almost immediately when they leave, and then for a few weeks after release to counsel them. So we think that there's a chance that some other health behaviors improve as you're trying to improve your smoking. So from this work, I've taken away a few important points, and Julie and Peter, if you have other key takeaways you think would be helpful, please chime in. Data can identify the scope of local health problems. We don't need to guess. We don't need to use anecdotal information. We don't need to say, like, I heard on the ground that this is happening. That is important, and that should inform the research or the data questions that you ask. But we have data available. You often don't need to collect it. It's somewhere. You need to find it and figure out how to use it. And it can be incredibly valuable to inform crises that are unfolding in our community. One of the things that I really appreciated about this study was that from the get-go we included decision makers. So people, not me, who can make real decisions and change things at an early stage, and it makes the data so much more impactful. So Julie is I consider a decision maker, or at least links us to other folks who can make decision makers who were informed from the very beginning, and we had buy-in from a very early stage. I think particularly for someone who's coming from a more academic background, like, this point is often lost, in that it's so much more impactful to get buy-in on the front end and make those partnerships and those connections before you go down the rabbit hole. Otherwise, you often could just end up with data and then try to go sell it. But when you're sort of searching for the answer together, it feels a lot different when you have some conclusions. And so I think that's just so important. The other thing, like, it seems like an opioid intervention in the criminal justice system, or even in one jail, seems like a really niche issue. But these targeted interventions can have very large public health impacts. So we used data and we identified hotspots. And you can intervene in this one place. And if people stopped dying when they left the Hennepin County Jail, you would reduce opioid overdose deaths across the state by 10%. And that is nothing to sneeze at. The final thing that I want to talk about is how to start understanding these incredibly complex systems. And so I would consider the project that I'm going to discuss the kitchen sink approach, which is like you just do everything. It's not always necessary, but this, I think, is a methodology that's really going to massively expand our understanding of the relationships between healthcare and community supervision. I've had the opportunity to collaborate with many stakeholders in Hennepin County around data integration work, and Peter has been the primary analyst who has been linking these data, and we've worked with many stakeholders across many departments to link healthcare, criminal justice, housing, and human services data to understand the Medicaid expansion population, so the group of individuals who gained health insurance, public health insurance through the Affordable Care Act. And what you can see is that even a super simple crosstab of service interactions is remarkably powerful. And you can see here, that 34% of the expansion population was touching the criminal justice system. That's important, and especially when there are policies in the criminal justice system that make the health system work less well and vice versa. And once you link all this data, you can do remarkable things with it. So you can start to look at key subpopulations that stakeholders might be interested in, and you can figure out sort of how much public money goes to those populations. And so if you look at folks who don't have mental illness or substance use disorders, those that have mental illness, substance use disorders, or both, you start to see, for people who might only care about dollars, the importance of addressing behavioral health issues for folks who have public health insurance. So we wanted to build off of this experience using integrated data to understand the relationship between community supervision and health. As I previously told you, justice involvement is strongly associated with poor health and health inequities. We know a fair amount about the relationship between health and incarceration, but we know a lot less about what happens on community supervision. I would say 95% of the literature around sort of health and criminal justice involvement is focused on jails and prisons. Once they leave, but are still involved in the justice system, our understanding really starts to fall apart. So this is an interesting opportunity in Minnesota because we have the 46th highest, so 5th lowest incarceration rate in the United States, and we have the 5th highest probation rate. And so because of the high level of community supervision in Hennepin County and the ability to link data across these complex systems, we thought we had a real opportunity to understand this relationship. The university has been instrumental in this work. They have an initiative called Grand Challenges. In academia, it is very common for departments to be very siloed, so that health research takes place in the medical school, and public health work takes place in the public health school, and so on. And funding agencies sort of encourage that type of work. And it can be difficult to find grant dollars that fund very interdisciplinary questions. So the university decided that they were going to step up and fund interdisciplinary work that could make a difference in large problems facing our community. And this is sort of an unheard of type of funding opportunity. And so they put out a call for grants around this idea of fostering just and equitable communities. And that's what's funded this work to date. So this is an interdisciplinary cross-sector team. Includes multiple departments at the University of Minnesota. I'll probably miss some, but it's sociology, pediatrics, medicine, School of Public Health, School of Law, and the business school. I'm sure there are others. Hennepin Healthcare, which is me and some of my research staff, and then a variety of folks in Hennepin County in the Office of Enterprise Analytics, in DOCCCR, in Health and Human Services. And we asked what are the health conditions, healthcare use patterns, insurance rates, treatment rates among folks on community supervision in Hennepin County. How does health impact your ability to complete community supervision, and how does community supervision impact your health? And how do these disparities that exist in both the healthcare systems and the criminal justice system overlap and contribute to the disparities, racial ethnic disparities that we know exist both in Hennepin County and across Minnesota? One of the really cool things about this project is that we're taking what's called a mixed methods approach, which means that we're doing the data linkage stuff, and we're also doing a lot of qualitative work, interviews and surveys. So we're conducting interviews with physicians at Hennepin Healthcare, at Coop Clinic, North Point, Broadway Family Medicine, to understand what physicians know about the criminal justice system and whether or not they take criminal justice involvement into account when they're deciding on issues around care coordination and treatment. We're interviewing a group of, we're hoping, around 150 to 200 individuals on probation and follow them over time with serial surveys. These surveys are conducted in person. They take about an hour and a half. They're incredibly in-depth, and they provide us with rich information that we can't glean from the data linkage work. What we're hoping to do is take to both use the interviews themselves, but also to link some of that work to the quantitative data to understand how well what the administrative data in Hennepin County, how well that jives with what people say is happening in their lives. And then we'll be interviewing probation officers as well to understand how they think about healthcare for the clients that they serve. So I did not put this slide together, but I am just stealing it from a conference that we co-presented at. And so this gives you an idea of the data sources that are being linked in Hennepin County. There is probation data, demographic data that comes from DOCCR, criminal history data that comes from the courts. And then there's detention and incarceration data that does not sit in Hennepin County, but comes from the state. So that's all of our criminal justice data. And we're pulling out individuals who are on what's called 40 to 1 probation, 40 clients to 1 probation officer, which is considered high-level supervision. And then we're linking that to Medicaid data and other health, public health insurance data, human services, and housing. And so we can really understand a lot about how people move through Hennepin County and how health may or may not impact their experience while they're on community supervision. So this is just some preliminary data to give you a sense of what this data looks like and what it can do. These are just the demographics of our population who started probation in 2016. So this is high-level community supervision. This is the Hennepin County general population. So the probation population is mostly male. And then you can see the just stark racial disparities. So 69% of Hennepin County is white non-Hispanic. In our population, they make up 37% of individuals. African American or Black is about 13% in the general population and 49% in the probation population, almost half. And Native Americans, while a small part, relatively small part of the probation population, are massively overrepresented when you compare to their overall population in Hennepin County, and then our population is younger than the average Hennepin County resident. So this is illustrative of the type of data that we can generate. And so one of the things we're interested in is what happens to your service use when you hit probation. And so this looks at people who were enrolled in Medicaid time 0 is their start time on probation. And you can see that this is a year before, a year after, that as folks start to enter probation, there is just a very slight uptick in health insurance enrollment. If you look at other years, it's maybe a bit more obvious that there's an uptick. And so this suggests that, maybe folks are, being enrolled in insurance by their probation officer. And this gives us sort of data that we can then help inform the interviews that we'll be conducting for the probation officers and for people on probation.
Can I ask a quick question?
Yeah.
While they're in jail, they are not on Medicaid, is that right?
Yep.
Hennepin County or whatever, whoever the jurisdiction is responsible?
That's right. So Medicaid has to be either suspended, so through federal statutes has to be suspended or terminated when someone enters a correctional facility. So you legally cannot bill Medicaid for healthcare services while someone's incarcerated. And then the jail or the prison is responsible for supplying community standard healthcare.
I have a question on are there incentives for the survey participants, and how do they avoid loss to follow-up?
It's a great question. There is I think a gift card that folks get for participating. I don't recall off the top of my head what it is, but they do. In terms of loss to follow-up, I don't know. We just started the probation interviews. I think 11 or so individuals have been interviewed so far. I will say what I've heard from our team is that folks who are on probation have been extremely enthusiastic about participating, so that when we started reaching out to folks, there were actually so many people who responded that we had to pause our recruitment just to catch up with the people who had responded. Then during their interview, we get quite a bit of contact information about their contact information and then emergency contacts to follow up with people later on.
I have a question. So some of the drugs used to treat opioid addiction, I know there's varying approval of those drugs, or it can be hard for doctors to prescribe them because they need very stringent reimbursement practices. So when they're going from this community standard of care, is buprenorphine, you know what I'm talking about?
Yep. You can say bupe.
Bupe. Is it is that covered? Is that something they would receive while incarcerated? And if so, does Medicaid in Minnesota also approve of that? What's the continuity of care here?
Could you repeat the question, please?
Yeah, so the question is, there are regulations around medications to treat opioid use disorders, and providers need special waivers to prescribe it, do insurance companies and plans, including Medicaid, cover that medication, and how does that transfer work? It's a great question. It's complicated. I'll give you a short answer. So nationally, 98% of, well, this is probably a slight exaggeration, but most jails and prisons don't treat opioid use disorders. That's changing pretty rapidly. To prescribe buprenorphine, you have to have a special waiver through the DEA. So at the Hennepin County Jail, myself and Dr. Silva have it's called an X waiver through the DEA to be able to prescribe buprenorphine. That basically allows either addiction specialists, which I'm not, or primary care doctors, which Dr. Silva and I are, to prescribe buprenorphine for opioid use disorder. The medical director at the ACF has a buprenorphine waiver, and that's the only way to prescribe in a jail. So you have to have a provider who's waivered. Once you have the waiver, it's pretty easy. At the jail, we pay about $1.50 per pill per day for buprenorphine, and so it's 1 to 2 pills per day, and it's relatively cheap for us to do that. So Medicaid does cover buprenorphine. and no longer in Minnesota requires a prior auth. So they do not require prior auth, meaning like you don't have to give some reason why like they need this medication. It's pretty smooth. The linkage to care from jail to community is incredibly important. So when we just a few months ago started kind of letting people know that we were going to start prescribing buprenorphine in the jail, community clinics actually reached out to us and said, we want to take care of these patients. And so we have a list of resources at the jail and of clinics that we can call to link people to care. And then if people go to a treatment program, we make sure that they're going to a treatment program that lets them continue their buprenorphine. Does that answer your question?
It does, yeah.
So the other medication to treat opioid use disorders is methadone, and that's more complicated.
Okay.
So we're really interested in disparities in this project, and you'll see that once you start to disaggregate this information by race and ethnicity, it gets interesting. So the green line is Native Americans, the purple line is white non-Hispanic, and the orange line is Black or African American. So you can see that maybe there's a slight uptick for Native Americans, that rates of insurance when African Americans hit probation basically has no change, and most of the increase that we see in health insurance rates for folks when they hit probation is among white non-Hispanic individuals. So there's populations that are disproportionately impacted in the criminal justice system, and within the criminal justice system there are races and ethnicities that are disproportionately impacted further. Because we're able to link all this data, we can start to really understand granular information about the overlap of health and among people who are on community supervision. So we've picked out just a sample of the many health conditions that we're looking at. Here are some chronic conditions: hypertension and asthma, any mental illness and psychotic disorders, opioid misuse and methamphetamine use, and we compare them to national averages adjusted for differences in age and gender. And as you can see across the board, there's a much higher prevalence of all conditions, and the differences are particularly stark when you look at mental illness and substance use disorders. Again, when you break this information down by race and ethnicity, it starts to paint a far more complex picture. So again, purple is white, orange is Black or African American, and green is Native American. What you see here is that really across the board, chronic health conditions in the probation population, regardless of race or ethnicity, are higher than in the general population. For asthma, rates seem to be higher among African Americans or Native Americans. When you look at mental illness and substance use disorders, you see a much different picture. So when you look at any mental illness, rates are about equal among Native Americans and white individuals, and lower for Black or African American individuals. Rates are somewhat similar, although highest for Native Americans when you look at more severe mental illness, psychotic disorders. And then again, opioid misuse, highest among Native Americans. Whites are quite high. Both methamphetamine use and opioid misuse are much lower among African Americans. So what does that mean? The real answer is we don't quite know. One possibility is that there's underreporting among African Americans, that when they see the doctor's just less likely to indicate that they have a substance use disorder. That's one possibility. I think that's somewhat less likely of the answer, because I would expect that would also maybe happen among Native Americans. And we see that rates are quite high among the Native American population. I think another hypothesis that we'll be investigating is that there are very different reasons why different races and ethnicity end up in the criminal justice system. So that there may be that, if you're white, having a substance use disorder or mental illness is a strong predictor of your criminal justice involvement, and there are very different reasons why other communities might end up in the criminal justice system. So, takeaways for work that has been trying to understand how these complex systems interact. Merging of the rich data that you all have here in Hennepin County provides unparalleled opportunities to understand drivers of important outcomes across sectors. This is not happening in other places across the country. Maybe there are a handful at best. This is really novel, cutting-edge stuff, and it doesn't exist in most places. As someone who primarily focuses on quantitative data, this work, I think, really highlights the importance of qualitative methods that can provide really important insights that aren't captured in administrative data. And these projects that are trying to understand very complex things, they take time to mature. This did not happen in the course of 6 months. This has been developing before I was at Hennepin Healthcare, and has taken, I guess on the better side of a decade to develop. And so as folks want to understand this, just know that this is, you're kind of getting into it for the long haul, and that it will take some time. All right. That is all I have for today. I think I forgot a conclusion slide. But I really appreciate your attention, and it looks like we have a few minutes left over for questions.
Will you be sharing these slides with us?
Maybe. I have to ask my Hennepin County partners if it is, I can share some of the information. But if I can't, I will share most of them. Let's say that. Yeah.
I've been wondering what accounts for the 10 times overdose ratio of inmates after release. What's the reasoning behind that? Why do they just get back to their hometown and just go all out? And
yeah, great question. I think there's a couple things. So one is that if you've been incarcerated for a period of time, you've lost your tolerance. And so if you are released and then you go use the same amount that you were using before you went into jail or prison, you'll overdose, even though that dose never used to have the same effect.
I've heard stories of people taking hundreds of opioid pills a day and not dying because of their tolerance.
Exactly.
That makes a lot of sense.
Yep. That's horrible. The second reason is that high-risk individuals do enter the jail. I mean, they were high risk before they came in, and they were high risk when they left the jail. And so part of the overdose deaths is the nature of the nature of the health profiles of people who are coming into jail or prison. Yeah.
When you try to understand that why the African American population does not have such high rates of substance abuse, will you be looking at race and racism?
Yes.
And so it makes me feel that, yeah, that maybe it is because these people are in jail because of biases rather than real crime or minor crimes. And will you be looking at that?
Yes, and I think that that those important issues around race and racism are tricky to tease out in quantitative data, and I think that's where some of our qualitative work is going to be extraordinarily helpful and impactful.
It seems like that's what you were alluding to when you were saying different reasons why certain populations are incarcerated.
Yes.
And I'm guessing you meant African Americans in particular, because their rates are so low.
That would be my hypothesis. Other questions?
Well, thank you all very much. I'm Kathy Doty with the Hennepin-University Partnership, and I want to thank Dr. Winkelman very much for his presentation.
And I also want to really celebrate this really strong connection with Peter Bedurtha and I mean, you really have some top-notch researchers here within Hennepin County, and it's really great when we can connect them up with top-notch researchers from the university. So I think if you have questions or thoughts, and you don't hesitate to follow up with your peers at Hennepin County, or can they also follow up with you?
Absolutely.
Okay, great. So because I think there's probably a lot more questions and a lot more things that people would want to know, and I think don't hesitate to let us know if you have more questions. We'll try to answer them. Thank you very much.
Thank you.